Good afternoon. I'd like to thank the organizers for the opportunity to talk today and to highlight the work that was made possible by the George and Angelina Kostas Research Center for Cardiovascular Nanomedicine. The work I'm going to talk about today is actually a spin-off from a project that was previously funded by the same center. We had a grant looking at nanotherapeutics towards heart failure, and what we actually found was that in the presence of endothelial dysfunction and permeability in that disease actually led to nano and microparticle accumulation in failing hearts. And so in talking with Dr. Guillermo Torre here at the Houston Methodist Debaki, and with Dr. Ashraf Guha, who is the co-PI on this project, we wondered if it would be possible to extend this whole phenomenon to pulmonary hypertension. They seem to hypothesize that again, injurious events that occur in pulmonary hypertension actually also gave rise to the fenestrated vasculature, which has been so transformative, I guess, in fields such as cancer. So with that, I think I'm going to get started. And again, I'd just like to thank, again, the George and Angelina Kostas Research Center for Cardiovascular Nanomedicine, because without their support, this is a field that would have largely remained unexplored. So by way of significance, again, pulmonary arterial hypertension is a progressively rapid and fatal disease with incidences and mortalities that actually increased over a time span of 2001 to 2010, when the last surveillance study was actually performed. The end stage of pulmonary hypertension is right heart failure. And between 10 and 30% of heart failure admissions in the U.S. are a result of pulmonary hypertension. Again, this is significant as well because heart failure is the number one cause of mortality in the Western world and developed worlds, or emerging as well. And it's the number one cause of hospitalization in the U.S. And again, so the prognosis is pretty dire. So it's a 3-year survival. Which again rivals that of many cancers as well. The treatments that do exist, or treatments that are out there, are more symptomatic than, as you could say, disease reversal or curative. The only curative option actually is lung transplantation, and with the limited amount of donor lungs and associated risks, again, there is an urgent need to develop novel therapies. By way of definition, so PH is a disease of the small pulmonary arteries, and basically what happens is there's an increase in pulmonary vascular resistance, and the vascular changes that are seen as a result of, again, endothelial dysfunction is that we see vasoconstriction, we see smooth muscle cell and endothelial cell proliferation, and thrombosis and fibrosis. And again, going back to the right heart failure, what happens is that the right heart actually gets strained by pH, and it hypertrophies in an attempt to compensate for the systolic requirements, and it's just not able to. Resulting in right heart failure. Again, pulmonary hypertension is classified among the different groups depending on etiology. So you have idiopathic, you have hereditary, you have also caused by drugs, pulmonary hypertension in group 2 associated with left heart disease. You have group 3, which is associated with COPD. And 4, which is a chronic thrombotic disease, and 5, which is just miscellaneous, that there's no reason or rationale for why they should see these pH in these conditions. Again, going back to the current state of treatments, or the treatments that are actually out there, Again, so mostly symptomatic, not really focusing on reversal. A lot of them do target these three pathways because, again, endothelial dysfunction kind of lies at the crux of everything associated with pulmonary hypertension. What there is basically an imbalance of production of vasoconstrictors and vasodilators. And so typically the treatments either consist of, for example, delivery of prostacyclin or endothelial antagonist, and or a combination of these as well. And they all actually, with the end goal of modulating vascular tone. Again, so there are several limitations associated with the current delivery strategies. Chief among them, if we just look at the prostacyclin pathway and we look at one of the more common drugs, epoprostenol, so that drug has a severely short half-life, about 3 minutes in circulation. And so it requires continuous infusion by a pump located externally, and that is connected via catheter and in a continuous, in a central vein, sorry. And so, I mean, this is obviously not the most ideal delivery strategy out there for several reasons. I mean, it's costly, it's complicated, it's not very patient compliant. Not to mention that it is a risk of sepsis, which is very bad. Also, the pump can fail, or the catheter can dislodge, and that can even be life-threatening. So there is a need to, and these are the therapies that are out there right now. So we have inhalationals as well, and there's some subcutaneous ones as well. But again, there's also a lot of adverse side effects associated with many of these drugs that kind of beckon the exploration of novel therapies. So one of the reasons why, as I mentioned at the beginning of the talk, one of the reasons why nanoparticles were so effective in cancer and were able to impact chemotherapy to the extent that they have is because of this of the observation, I think more than 30 years ago, by Maida and co-workers, where they observed this enhanced permeability resulting from the angiogenic vessels in tumors, and they were actually seeing enhanced accumulation in tumors because of the fenestrated vasculature. And so when Dr. Ashrith Guha and Dr. Guillermo Torre approached us about exploring nanotherapeutics in pulmonary hypertension, this was kind of the hypothesis that, again, the injurious events such as hypoxia and inflammation would actually cause maybe focal disruption in the vessels that would allow for nanoparticles or small molecules to actually extravasate from the circulation into, for example, a smooth muscle layer or the tunica media. But that's not the only. So there's also increased shear mechanical stress that maybe induces stretching, and there's a presence of fenestrations, and as well as, for example, one of the molecules that we're interested in, BMPR2, has also been shown that when it's reduced in pulmonary hypertension, it actually induces endothelial cell apoptosis, and again, so it kind of leaves this interrupted vasculature, not continuous vasculature, and this is what we kind of wanted to take advantage of, and where we thought that maybe we can contribute something, a nanotherapeutic platform for pulmonary hypertension, and so we set out to test that hypothesis. So Victor in the lab, who's there in the back, fabricated these nanoparticles, very small in size, about 20 nanometers in size, and injected them intravenously, but they were loaded with a fluorescent, highly hydrophobic fluorescent molecule. After 24 hours, he was actually able to look at one of the pulmonary vasculature and actually see the nanoparticles located in this region that actually corresponds to the tunica media. And this is actually, you can see it also in this. here, which is it's kind of a heat map that shows you where the majority of the fluorescence is emanating from. And so this is very significant, and it was a pretty good finding for us because this is exactly where we want to go with our nanoparticles. A lot of our target cells, so we're either targeting the endothelial cells or we're targeting the smooth muscle cells, and that's to be able to get the nanoparticles there and potentially release drugs or genes in a sustained fashion is what we were kind of going after. And as a proof of concept, so we wanted to say, okay, well, now that we know that the nanoparticles can accumulate in the tunica medium, we wanted to, so why don't we see if we can actually exert some sort of therapeutic effect? And we chose to target mTOR. So again, so the AKT-mTOR pathway is barely activated in diseases ranging from cancer to diabetes, and it's also barely activated in pH. So it's also regulating the growth and proliferation of smooth muscle cells. It was shown preclinically in the rat model, a monocrotaline model of pH, to actually prevent progression of the disease. And it was also shown clinically, I think, in a pilot study in Germany, where pH patients actually they had an increase in 6-minute walk distance, so their exercise tolerance went up, and they had decreased mean pulmonary arterial pressure. So we decided to use the drug rapamycin loaded within nanoparticles and delivered intravenously to these monocrotaline-induced model of rat. Again, so here's basically the nanoparticle platform that we chose for this. Again, very small. It's about 20 nanometers in size, 20, 30 nanometers, and it actually proved pretty effective for rapamycin because, as you know, rapamycin is very hydrophobic. And so we needed a nanoparticle that was not, that could actually accommodate a hydrophobic drug well within its core. And we had this, and actually it was protected by a hydrating layer of polyethylene glycol. And so the loading, the water solubility went up several fold actually after incorporating rapamycin within it. So when we administered it to a rat model of pulmonary hypertension, which is induced by a single monocrotaline injection, you can see here that this is what a healthy arteriole looks like, and then this is one that's been undergoing pH, a diseased, and then this there we go, and this is what happens after about, I think it was a 4-week treatment with nanoparticles biweekly, and so we were actually able to prevent this hypertrophy. And again, so we quantified it, and indeed, yes, I mean, there was a clear difference between the disease and the free drug and the nanoparticle. Not so much, but we were able to prevent disease. Importantly, also, we were able to show that we were actually hitting the target when we took lung tissue and analyzed it for phospho-6, which is downstream of mTOR. As you can see, mTOR is activated in the disease, but you actually don't see it in either the RAP free drug or the nanoparticle form. So that was pretty significant as well. There we go. So again, so we're talking about the effect of pulmonary hypertension on the on heart failure and right heart failure. So what we saw was again the disease led to right ventricular systolic pressures that were pretty high, and we were able to keep that low with the treatments. Heart rate was again also reduced. And the Fulton index, which is basically taking the right ventricle weight and dividing it over the weight of the left ventricle plus the septum, again, very, very low. And when we looked at it under histology, you can actually see this fibrosis in the right ventricle and the disease, and in the nanoparticle, you couldn't. So significantly, this is pretty good. So with, again, nanoparticle formulations, again, one of the advantages is that they do overcome not only pharmacokinetic limitations, but also either vehicle-induced or drug-induced toxicities. And what we saw here is that when we administered the free drug, rapamycin in free drug form, you did see a loss in the weight. But when we administered it in nanoparticle, weights kind of stayed the same. I mean, they didn't go up, but they also were slightly maintained. And significantly, we did not see any inflammatory cytokines compared to, or differences compared to the free drug. So that was pretty we're pretty happy about that. So with regards to this study, we were pretty excited that we were able to show that nanoparticles accumulated in the pulmonary vasculature, specifically where we wanted them to accumulate to. It effectively prevented the disease progression, and it reduced some of the toxicity that was compared to free drug controls. And now, Mauro Ferrari, the last time we showed him this, he was actually made a point that we had to stress the fact that a lot of the nanoparticle formulations that have been approved for clinical use, I mean, if you look at them, if you look at the liposomal doxorubicin formulation compared to doxorubicin by itself, or if you look at Taxol compared to Abraxane, which is a nanoparticle albumin-bound paclitaxel, the efficacies are, there's been a lot of JCO publications out there where the efficacies are more or less the same. Where there is a distinct advantage is in this ability to overcome a lot of either the vehicle-induced toxicity or the toxicity of the drug itself. In the case of doxorubicin, you got rid of the cardiotoxicity by incorporating the drug inside of a liposome. In the case of Abraxane, you got rid of the hypersensitivity reactions that was caused by the cremophore. And so that was that's what's led to these drugs actually being used. Again, the other thing that it showed us is that maybe we can apply nano-based delivery platforms, some of them more versatile, more creatively engineered than others, to actually impact pulmonary hypertension. So with that in mind, we set out to see if we could actually treat pulmonary hypertension using gene therapy, and playing on our strengths here within the Institute, specifically with John Cook on the mRNA side. We decided to, I'm getting a little ahead of myself, sorry, I forgot this slide was here. This slide here is to show that, again, so the generous gift of the Kostas Foundation, so it not only goes towards the research, but in this case, this is just to show that this is a work of Victor, who's in the audience, and this is his thesis. The rapamycin story and the story that you're about to hear as well. And so this is actually going towards his education. He's getting his MD PhD from Monterey Tech, and again, so he was able to actually submit this to present this at the American College of Cardiology in Chicago, and he won a Best Poster Award there. And then he was actually able to present it also at the International Society of Heart and Lung Transplantation, where he was actually invited for his first oral talk. And so the other good thing about this is that it was actually well received, so by the cardiology community. So this is it tells us that maybe we're onto something, or we have something that's quite promising. Going back to what I was saying before that about gene therapy, you're never going to find another target that's maybe in pH that's more notorious, I guess, than BMPR2, from what I'm reading and from what I talked to with Dr. Ash. I mean, so this is kind of the master regulator of pulmonary remodeling. Again, so it's a member of the TGF-beta superfamily. Here's basically the mechanism. So it binds BMP2, BMP4, BMP7, and interacts with TGF-beta through phospho-SMAD 1, 5, and 8. Importantly, it's found heavily mutated in this familial or hereditary pulmonary hypertension in those patients. Also, interestingly, it's even in idiopathic pulmonary hypertension, where there's no clear genetic predisposition or anything, there is a 25% or 25% of those patients have decreased BMPR2 expression. That's actually shown here in this graph, which is from Atkinson study in circulation, where they showed that even that BMPR2 is significantly lower in PH lungs overall compared to healthy lungs. And so this is a target that we would like to deliver an mRNA for targeting BMPR2. Again, so in actually it was 2015, not 16, but in 2015, so Mauro published a seminal paper on the biological barriers in drug and nanoparticle-based delivery. And again, he's been kind of at the forefront of this, transport barriers to drug delivery and how we have to overcome them. And it's not going to be enough to just take nanoparticles that have existed for a while and just add a targeting ligand or add a controlled release functionality to it, because it's the stark truth is that no matter how many of these papers we've seen, there are not that many multifunctional quote-unquote nanoparticles that actually do progress clinically. So, and again, because of the reasons why is because you do have these biological barriers, for example, the mononuclear phagocyte system, non-specific distribution, for example, ending up in the liver, the kidneys, and the spleen, or this applies to drugs and to nanoparticles as well. You have hematological limitations. For example, when you inject nanoparticles that are small in size, they're spherical, they actually tend to stay away a certain distance from the endothelium. Then again, you have this actual barrier of cell entry and endosomal escape. And so all these barriers actually kind of, they warrant a reimagining of your typical, drug delivery platform to sequentially overcome these barriers. And so what Dr. Ferrari has kind of has developed over the years has been this multi-stage platform, or multi-stage vector, which you see here is basically mesoporous silicon particle platform that has these nanopores that range about 60 to 80 or 90 nanometers in size, and that can accommodate these nanoparticles that in turn can accommodate drugs or genes. So it's a really Russian nested doll approach to drug delivery that gives you, added protection of cargo, which is very important if you're talking about genetic material. You get a very sustained release, which is also pretty good as well. And so interestingly also, so the diameter and the size gives us preferential delivery to where we want to go. And in this case, it's extremely important because so size gives us natural tropism to organs like the lung, and the geometry allows the particle to associate more with the vasculature through this tumbling motion and tumbling kinetics that it exhibits under flow. And so that was kind of where we kind of envisioned. So we would see here you'd have pulmonary vasculature, and the MSV would kind of just arrive and just locally release its cargo there, affecting the smooth muscle cells. And we know that the MSV can actually do this because we've seen it before. So this is a paper from 2012. We can see here these red dots are the MSV associated with the endothelial wall. And here, this is a paper from 2016, which is another seminal paper by Morrow and Haifa Shen, showing that this platform can actually, I think it was cure about 50% of mice that had metastatic breast cancer to the lungs. And so, again, so we can see the MSV associated with the vasculature there. So these are all design considerations that go into MSVs. Another design consideration is these nanoparticles that go into it. So you can engineer it so that it's able to enter cells more readily and escape endosomes also in a quicker way, so that the contents are not exposed to these degradative enzymes. So we basically came up with a lipid nanoparticle to deliver mRNA. Again, we looked at the size. They were about, again, 20, 30 nanometers in size, which is perfect to accommodate within the MSV. Again, they were very non-toxic, very much non-toxic endothelial cells. Transfection was really great. So we had, again, concentration-dependent effect on uptake and on transfection, again, especially over time. Western blots, transfection also look good compared to lipofectamine as well. And here in cells, we can actually see the mRNA in the protein that we were trying to express, which in this case was EGFP. And again, these are all on endothelial cells, one of the target cells. And then we put that in MSVs. And so actually they loaded very well in MSVs through electrostatic interactions and very high loadings. And here you could see just kind of a field. All these dots are MSVs. Here's a close-up. where we basically fluorescently tag the MSV. And the MSV is in green, the mRNA is in red, so you can see it actually going through these pores. Then we administered it to mice just to see if they would even accumulate in the lungs, and we actually did. So at 2 days, we're actually able to see the MSVs, and we can actually see the mRNA still associated with it. So that's, again, a proof that we are getting more sustained, kind of slow release from these. And then at 7 days, you do see the mRNA has actually diffused away from these MSVs. And so that's pretty impressive. And now the next step is to see if we can actually express the protein in those tissues. So just by means of conclusion, so this is kind of our motivating, kind of our driving force every day. So it's our thinking, or my thinking, that efficacious outcomes only are going to come out when you can site-specifically deliver the right drug. So I mean, you could have the best drug in the world, but if you can't get it to where it has to go, then it's all for naught. It's the same with the delivery. I mean, you can have a platform that goes specifically where it needs to go, but if you're delivering something that is not even effective against those cells or whatever you're targeting, then there's no point. And so what we try to do is just kind of, all of our projects are kind of trying to enhance specificity by addressing both of these. Again, we've shown that there is an unmet, critical need to get more precision-based therapeutic strategies in pH. That the physiology of pH does present an opportunity for nanoparticle-based delivery. Again, this is something we know that gene therapies are really hard to realize, I guess, clinically or in vivo, because again, there's biological barriers. Also, some of the vectors that they're using now are not the best. So that's something we keep in mind also. But if we have rationally designed nanoparticle-based carriers, such as the MSV platform, then we can maybe enable gene therapies. And so with that, these are the people that did the work. And Mauro is, he didn't, but he's gracious enough to mentor me, I guess, through everything. We have actually Ashrath Guha again, who just walked in. So he's co-PI. Keith Euchre, always amazing Keith, who is an expert on these animal models that we work with. Javier and Anna are the postdocs in the lab. And Arvin and Guillermo Torre. And then Harry Carmuti Quintana over at UTH. So he's looking at another aspect of pH associated with IPF, with pulmonary fibrosis. And again, targeting also not only vasculature, but macrophages as well. But that's a story for another time, I guess. And we are, again, as always, grateful for the generous funding provided by the George and Angelina Kostas Research Center. So.